So welcome everybody. We'll start this 14th webinar of the Quality and Safety Network organized by the European Hospital and Healthcare Federation and PAQS. We will, as always, share best practices and experiences around patient safety and quality of care, which is one of the most effective ways to learn from one another. We have had a lot of webinars over the past years. You can still go and review all these webinars online on the YouTube channel. We started in 2019 and we're already in 2022 with the last webinar of the year about a Belgian collaborative that was organized for 5 years. We do have one webinar already planned for 2023 about Denmark's experience after leaving the accreditation in hospitals for 7 years and how they've managed to ensure quality and safety in their hospitals. It's also something to look after. Today, we have a lot of people around Europe connected. 15 countries are represented in the registration. And well, thank you for joining today. I will leave the floor to my colleagues who work at PAQS, Quentin Sconvaar and Mathieu Guizet, who will talk to you about what has been accomplished in a 5-year program here in Belgium in hospital.
Thank you, Laura. I will just share my screen. Yep. Okay, it's done. So hi everyone. I see some well-known name and other new friend on the list, and today we will speak about our biggest project so far. So it was called 5 years to save lives. It was a Belgian breakthrough series collaborative that we have done mainly in the French-speaking part of Belgium, Brussels, and Wallonia. And we will try really to go around the project, but mainly on the results of the project to give you some insight if you want to pursue some likewise projects. So just as a reminder, PAQS stands for Platform for Continuous Improvement of Quality of Care and Patient Safety. Our mission is to promote, support, and organize the development and implementation of initiatives of continuous quality of care and patient safety improvement in Brussels and the Walloon region healthcare institution. So really, for those who know, we are kind of a small institute for healthcare improvement, really to provide some support on improvement with all the healthcare sectors in our region. Who are we? So I will be joined with Quentin. Quentin is the data improvement officer. He has a background as a demographer. He is also working on all the projects related to indicators. So all indicators reported by patient, all we know as PROM, PREM, and PRIM, and other quality indicators. And he's also our specialist in data analysis methods. And I will be also the second speaker for this webinar. I'm the head of improvement services, and mainly for this speech, I was the coordinator of the 5 years project. But this is not the main point, really. About the project, we will start by a global introduction and a point on the methodology of the project. As a reminder, it was called the 5 years to save lives. The origin of the project was really broad. The first point is that in the European Union, there was some information and some notes about how we can improve patient safety, mainly, and this is also related to the name that we have chosen for the project, is if we improve patient safety, we will directly save lives. So this project was really about how we can improve patient safety to save lives of our patient. Related on all the notes and paper published by the European Union, we had also all the directive from the World Health Organization, and we also go through all the accreditation referential from Accreditation Canada International and then Joint Commission International, two organizations that are mainly active in Belgium. So we really try to go through every main and very important paper and publication about patient safety, and to find the common point between all those organizations and all those texts and publications by all those organizations. This brings us to identify 5+1 thematic. The five main thematics were infection control and prevention, identity check of the patient, safe surgery, communication during handoff, and high-risk medication. We had a sixth thematic, especially for psychiatric hospitals, and we work with them on violence prevention with them, as they don't have safe surgery, and it's normal in psychiatric hospitals. Those six thematic bring us to identify some more specific, more small thematic, and we identify 6 sub-themes on this project. The first one related to infection and prevention, control of the infection, was hand hygiene. Then about the identification of the patient, the primary identification in hospitals when the patient arrives in the organization. About safe surgery, we have worked on all around the timeout procedure in the operating room, and about all the communication, especially on the communication during internal transfers of patient, and about high-risk medication, on identification and securization of the high-risk medication in the hospitals. And for the psychiatric hospitals, we have worked on the evaluation of the aggressive behaviors risk for the patient, for the other patient, and also for the staff. The steps to go through this project was first to engage every participant in the project. We use a kind of compact, kind of a contract between all the organizations. So we sign an agreement between PAQS and the organization who take part in the project. It was signed by PAQS CEO, but also on the other side by the organization, so hospital CEO, to really try to have the right people on the table, and to have a formal engagement with the participant and our organization. But perhaps the first point on this contract is that it was not a mandatory contract, so we asked them to sign, but there is absolutely no risk to them if at one point they wanted to break the contract. So I think it was the first point. If you want to engage people more, you have to have some kind of some incentive to really engage them and to bring them to the table. Then the second step was to teach the people how we can work with a collaborative breakthrough series, what is improvement, what will be the methodology that we will use. So really a first bundle of executive education for the people to work with us in the project. And then together with all the participants and PAQS team, we have set all the goals. We have chosen the goals that we aim to follow and to pursue and try to achieve. So it was really a common decision between PAQS and all the participants. And then we run the collaborative series with all the participants. The idea is really to use some evidence-based, some literature, and some previous experience that we had with people, to put in place some project, sub-project, and some action on the field with the frontline staff. And then after that, the last steps was really to spread what we have learned with this project, and it will be the main point of the end of this presentation. To put action in place into the organization regarding the different topics that we have chosen. we used change package. Change package were draft based on evidence-based practice that we can identify in the literature and all the scientific background that we have at PAQS and with the participant. And it was really used to guide the participant, to help them to choose the action they want to put in place. So it was also, as we defined the goal and the aim together with the participant and with PAQS, we also try to choose the practical action that they want to put in place together. So it was really a work together, not something top-down, really bottom-up, to find the best way to change things in the system of each organization. In terms of participants, we had 19 hospitals, and on those 19 hospitals participating in the project, we had 6 psychiatric one that joined the project. So it was really a success on this point to the whole publicity and not publicity, the whole advertising that we have done on the project, but really to think about all the people that we can reach with 19 hospitals on the table. And so I will let Quentin present the main results of the project after this small introduction.
You keep the control of the presentation, or I take it? Yeah. Okay, you can go. For collecting data, at the end of the project, we have operationalized 2 surveys to collect this data. The first survey assess the achievement of the initial goals in each subthemes. The second survey assess the implementation of evidence-based practices. It was the action that the hospitals can test in the project, and we evaluated this action, if the hospital make this action or not. And finally, at the end of the project, after these 2 surveys, we organized a focus group to collect the point of view of the project coordinators about these survey results, and to have other qualitative information about these results, and to have other information on their on the success or the failure on this project. And we have also qualitative information collected. We have also collected qualitative information on this project. Mathieu, you can go, Mathieu, on the next slide. We have a good a lot of response on this survey. For the first survey, we have 14 hospitals who responded to the survey, and for the second, only 13. But yes, we have also during the project hospitals who leave the projects, and all the hospital don't answered to the survey. We are aware that there is a problem with the no answer, because maybe this hospital who don't answer to these 2 survey, maybe they leave the project and then don't achieve the initial goals the initial goals of this project. But we have data about a huge part of the hospitals, and we can see this data. For example, if we look the goal achievement of each subthemes, Mathieu, you can go. We can see in this figure, we can see that there is 2 themes with more than half of the hospitals who achieved their goal. It's the hand hygiene compliance, we have 64%, and the primary patient identification. You can see, Mathieu, it's the 2 first thematics in terms of implementation and goal achievement in our project. We will see after why, but we can see other thematics. You can pass the dia. We have after we have another thematic who was well worked. It was the safe surgery with 55% of hospitals who achieved their goal and 36 who achieved partially their goal. And finally, we have 3 themes, subthemes, who were less well worked. For example, the management of violence in psychiatric institution. Only 33%, only 33% achieved their goal, and more than half of the hospitals achieved partially their goals. We have also the management of high-risk medication, and the communication was not very good, particularly the communication, because 58% of hospitals says they did not achieve their goal, and only 30% achieve their goal. And we have a lot of interrogation about this result, because we say why some thematics are more or less well worked and other thematics are not well worked by hospitals. We have some indication when we look the action they have implemented during the project. We can see this on the next slide. Remember, we have identified a change in the literature, in scientific literatures, and for the 6 subthemes, we have identified 96 change ideas to test, for hospital to test in the 6 change packages. We have themes with more change ideas than other. We will see that after. But if we look the 13 hospitals surveyed, we have more than 1,015 action who can be implemented during the project, in fact. And we will see in the figures here that 23% of this action was already implemented before the project. This shows that the hospitals have already worked some thematics, some themes before the beginning of the project. We will see also that 34% of the action proposed were tested and implemented during the project. It's the more important result for us, because we see that more than 300 actions were tested and adopted during this project by hospitals. We also see that 8% of action were tested and not implemented durably, and more than 300 actions were not tested during the project. After that, we have another question. We will ask if we have a correlation between the goals and actions. And when the goals were not achieved, we suppose that the healthcare organization have less implemented change ideas. And this hypothesis may be checked, because we will see here in this data, Matthew, you can pass the dia. We will see that there is a positive correlation between the percentage of action implemented and the percentage of hospitals who reach their goal. And we have a positive correlation coefficient. And we see that when you achieve your goals, you implemented more action. When we speak about implementation of action, it's the action implemented before the project and during the project, because you can work these thematics since many years and have also action for action implemented before this project. We will see that in the themes were very well worked. For example, hand hygiene and patient identification. Many action was already implemented before the project, and you have also many new actions who are implemented during the project. And we will see that there is more hospitals who reach their goal in this with these subthemes, maybe because they have a greater experience in the work of these two themes. Okay, we have also another thematic, the safe surgery, with many new action implemented, combined with a few already action already in place. For example, I don't remember, but some of hospitals have already a chirurgical checklist, because some of them have this checklist before the project. But during the project, they test they tasted also other action during this project. Finally, we will see also that, if I remember, for the high-risk medication management, it's a little bit paradoxal here, because you have many action who was implemented during the project, but not a lot of hospitals say they reach their initial goal. Their initial goal, it was to have a list of high-risk medication, and to see if this list is well implemented on the floor, on the units. And we will see here that all hospitals have created their list during the project. Half of the hospital created their list during the project, and 41% have this list before the project. And we can see that this project have a good impact for hospitals who don't have a list of high-risk medication, and who implemented a list during this project. But the problem for high-risk medication, it was the audit and the idea to check if they arrive to reach their goal. And this is the problem with this thematics. They implemented some action, but not enough action to achieve their goal. Yes, and for the two last thematics subthemes, it was the more problematic subthemes. We have the communication between professional for the handover, and the management of violence. Here we have not many action was not tested during the project. For example, for coordinators, it was difficult to implement communication tools between teams. And they say they have to assess an oral communication between member staff, and it's difficult to evaluate this oral communication, and they don't arrive to achieve their goal due to these difficulties. And we will maybe we will check these problems later, because we can, for example, use other tools to achieve these goals. For example, the team steps tools, to maybe it's better adapted to achieve the communication goals in this situation. But we will see, we see in these results that the hospitals don't achieve a lot this goal of communication, on communication. And finally, we observe 4 big explanations for this mixed result. This mixed results. The first is the themes with we have themes with greater maturity than other in Belgium French-speaking hospitals. You will see, for example, in the previous figures, that hand hygiene, for example, we have a lot of action already implemented before the project. In fact, we have 99 action already implemented before the project by hospitals. It was 40%. For example, 73% of hospitals had already a campaign to promote hand hygiene, and that campaign was operational before the project 5 years to save life. It's the same for a team to monitor the program for the promotion of hand hygiene. 60% of hospitals had a regular updating of training on hand hygiene. 55% of hospitals provided promotional material in the workplace. And we will see in these terms that we have a great experience in Belgium hospitals on these thematics of hand hygiene, because we have since several years a national campaign and other groups who promote these thematics in the system, in the Belgium-French system. For example, the last thematic, the thematic who was not very well implemented in the project is the communication during handover. We have only 5% of action who was already implemented before the project. For example, the action who was with the best result of implementation before the project, it was an information system that guaranteed the access to the data necessary for practitioner before the handover. For example, you have an access to examination result, to prescribed drugs before the handover. And you will see other results. For example, only 8% of hospitals had an interprofessional communication during patient handover is included in the institution, and this communication is included in the institutional strategic plan. And we have, yes, we don't have a good experience in these terms of communication, good experience in Belgium, a good maturity in these thematics, and it's why we can see mixed result between these two terms, in fact. Another reason to explain the mixed results, it's the suboptimal use of measure in a perspective of continuous improvement. In fact, in this project, we want to have a use of measure in the perspective of continuous improvement. We ask to hospitals to produce data in run chart or in control chart, like this example. It's an example on observance of hand hygiene. And in each change package, we have two key actions to see if the hospitals reach their goal. In fact, they have to implement to have an implementation of quality audits to ensure the collection of indicators, and also to analyze these indicators and to return the result to the team involved in the project. And with the results of this data, we can assess if the institution achieve or not the initial goals. And in fact, we see that many hospitals don't achieve their goal because they don't make audit or they don't return the result to the team involved in the project. And sometimes it's a little bit problematic because they don't collect data and they don't arrive to see if the goals were achieved or not. You can pass the area. And yes, we have two success factors for this this point. You can see, in fact, in the data here that the results were when the hospitals implement action on the audit action or not, or partially, or not at all. And we see that, for example, for hand hygiene compliance, that a third of 33% of hospitals implemented already this the audit before the project. 25% implemented this during for example, during the project. 25% implemented the audit, but abandoned this this audit, and 17% don't achieve this action during the project. And we will see that we need to have have team training for an optimal use of continuous improvement measure. It's important to make sure that this kind of project can have the results. We can have good results. And the audit must be delegated to professionals involved in the improvement project. This is a constatation made by project coordinators during the exchange when we speak about these problematics with them, in fact, and they say that it's important to delegate this this audit to professionals involved in the project. The third problematic who explained the mixed results was the human factors. In fact, we have a lack of staff involvement and a high staff turnover during the project, and it was difficult to promote the improvement works in this condition. And we have also the COVID-19 during this this project, and this crisis was also problematic to involve all the staff and all the team during 5 years in the project. And the fourth reason is linked to the third one. It's the longest. The longest, the 5 years. It's maybe a little bit more long, too long for hospitals to ensure the continuity of improvement work over a long period. And yeah, that's there is a correlation between this long period and the implication of staff during a long period. And we have interaction between these difficulties. I explained that we have a correlation between human factors and implication of human factors and the difficulties due to the long period of the project. But also we have a correlation between the staff involvement and a suboptimal use of measures during the project, because some professionals don't have a good training on the use of these data and the methodology to analyze data, and sometimes it's difficult to continue the project when we don't have this resource and this methodology to analyze the data.
Thank you, Quentin. So this is the first main part of the outcome of the project, really to see that there is two key factors on such great project. The first one is the scientific background and the creation of the change package. And for that, Anna, our colleagues in charge of creating the change package, have done a huge work on reviewing all the evidence. And the second one, Quentin just told you about this, is really about how we measure, how we analyze the measure, and how we follow every improvement and progress during the project. And we are now at the last part of our presentation. It was the general conclusion on the project. And what we can ask about this project is it was a failure or a success? Do we fail or do we succeed into this project? And in fact, I think when we see all the results that Quentin just showed you is both. If we look at the project as a macro level, it's really perhaps more a failure than a success, because we have seen that we don't progress as we intended at the very first beginning of the project as far as we thought. So it can be a failure, but it is also a huge success, perhaps more at a micro level, that because we achieved to train people, we achieved to sensibilize them on the importance of measure and all the improvement methodology. We also put in the light some very good work done by all the hospitals, especially on the hygiene and all the prevention and control of the infection, and also on some thematic. The safe surgery was really also, I think, a very good point with all the implementation of the timeout. And there was some part of the project really that was harder to put in place and really more tough for the staff. And the second thing that also had a very huge impact of the project is that the 2 last years of the project were impacted by the COVID-19 crisis. So really it changed all the plan. It changed all our plan, but also the plan in all our participant hospitals, just because it modified all our organization, all the priority. And we must admit that the crisis had really a very big impact on this project, because everything was almost stopped during those 2 years of the peak of the pandemic that we have seen everywhere in each country. The third point, for which I think is a success, if we look at we really sense the importance of the staff, and it's perhaps the point where we must, in all improvement project, bring more humanity in what we do, the work that we do with all the staff in each ward, is that we must take into consideration how they feel, what are the background, what are their priority, because it's so important. We come with improvement project and ask one more thing, but in fact they have already a lot of things to do. And when we speak about change management, about project, about improvement, we must start by the kind of a burning platform. And for the moment, the issue of all those projects of improvement are that everything is burning for the moment. So which one do we choose as a burning platform? Does it was the infection prevention control, the management of crisis, the staff shortage, the retention of professionals into our institution? So everything is burning for the moment. So choosing a burning platform is really hard, and for the front staff line, it's also really tough to try to be involved in our improvement project. So I think one of our job is really to put more humanity, to understand what they lived on the field, and to really take this into account in each project that we want to put in place in the near future. We must take care of our staff as they take care of our patients. And I think it's really also one of the key learning of this project is that we must provide tools and methodology to our staff that are easy to use. Like that, they can put it in place really to help them to achieve their first and initial mission to take care of the patient. So for that, all the improvement teams, all the quality coordinator that we have in our hospitals, the main focus of all those people must be on the staff and perhaps not directly on the patient, because we must take care of our staff as they take care then of our patient. And the last point on which I can conclude on the project is really the importance of adaptation of each project. The project was first designed to be something common going through every participant, every organization. And in fact, we perhaps had to be more adaptive and to make more adaptation for each participant to take the local context, the local culture into account. So it's really important in each improvement project, even on this one, on the 5 years to save lives, to go deeper into adaptation, because adaptation is really the key to get adoption of organization, of people, of staff, and everything in the project. So it's why the conclusion of this project is really a blend and mix of failure and success. But I think it was really a success, at least for the participant and PAQS, because we learn a lot. Every person on the table really learn a lot during those 5 years of project, and we achieve some very great results. So the conclusion is that we can perhaps say that we achieve to improve patient safety, so we achieve to save at least a few numbers of lives. So we achieved the aim of the project. The big aim of the project is that we had 5 years to save lives, and the conclusion and the answer to this question, do we had saved lives during those 5 years, is yes. I think that we have saved some lives, but perhaps not as many as we intend at the very beginning of the project, but really it was a success in terms of learning, and we learned a lot really together between us, between the participant, and between PAQS and the participant. So I see that we are almost at the time now for the question, and I just have a look on the question. I don't know, Laura, if you identify some question already.
So yeah, there was one question in the chat about the use of the safe surgery checklist. Was it just a timeout, or was it a whole safe surgery checklist that had to be implemented? Just one indication of that.
So during the project, the idea is to implement the full checklist of the WHO to have a more safer surgery. But in fact, as you see, we identified the big theme. It was the safe surgery with the checklist of the WHO. But we chose to work on the first year, and in fact, it was during the 5 years to work on a part of this checklist. It was the timeout. Really, this small part of the checklist that we try to implement into the operational room, operating room. Sorry.
If anybody has another question, please enter it in the chat. But I do have a question for you guys. So if you would give any recommendation to others, you said make it shorter, not 5 years, give an incentive, and adapt to your own context while taking care of your own staff. What recommendation do you take in your future activities at PAQS?
So I think all those conclusions was already in the process of designing the next strategy at PAQS. So really to take into account the local context, really to adapt, to adopt is my motto for the moment, really a kind of mantra, as really adaptation is the key to adoption. And I think it's the biggest learning that we have. And then do not forget that you must really teach and train all our people about measurement, about how to make a very good review of literature to find the best way to improve the thing. So really those 3 things perhaps put a huge investment on evidence-based practice, then try to make measurement and survey as easier as it's possible for the frontline staff, and then adapt to adopt. And on the length of the project, really the duration, 5 years, it was an issue for our project because there was a lot of participants. I think at the size of one organization, when you put some kind of project in your organization, you can try to set up the project on 5 years, but you must keep in mind that you will have a lot of turnover in your staff. So you must put in place something of a continuous learning or knowledge not transfers between all those people if you want that your project succeed in the future. So I think it's really the key point that we can learn and share with you all.
Mm-hmm. My questions did pop a new question in the chat. So it's kind of linked with mine, but what is the future of PAQS activities? Will it be a next 5-year action plan, or do you have other things in mind?
So no, if the question, do we will have a next 5 years project? No, because as perhaps an organization that work more on a macro level through many organizations, 5 years is too long for us to manage every turnover in every organization. I think really the key message I want to deliver is really that 5 years, it's okay at the micro level, at the size of one organization. For us, at the macro level, I think we will never do any more 5 years project, maximum a 2 years project. I think it will be okay for us in the maximum. And in fact, if we look at the theory of the collaborative breakthrough, it more between 6 and 18 months project. So it's really shorter than 5 years. And I think we must stick more on this model of the breakthrough collaborative series.
Yeah, but initially we have the plan to have more than one subthemes for 5 years. We have a plan to have maybe 2 or 3 subthemes by big thematics. And yes, it's why we choose to work on 5 years, but yeah, it was difficult.
Mm-hmm. Yeah, so to answer Sophie's question, it's less topics and shorter duration. I wouldn't say less topics, but maybe one focus, not to have too much topics, shorter duration, of course. I see here also a question coming up about long-term vision. I might answer that because we had a webinar in 2019, I think, about what PAQS has developed about a purple book, which is kind of a regional strategy about quality and patient safety in French-speaking Belgium. So that's kind of a multi-long-term vision on quality and patient safety here in the French-speaking part of Belgium, which kind of answers your question. So yes, we will continue working on patient safety and quality of care. We will just have shorter programs and a more focus on, like what Mathieu said, about caring for our staff, measuring, training, etc. I don't see any new question in the chat. Oh, we do have one. Regarding human resource shortage leading to high turnover, any suggestion to conduct future quality improvement projects?
A very good question, and it will ask more than a few seconds or minutes to really deeply answer to that. But I really invite you to focus on one thing on which I work a lot for the moment, is what matters to people, and really to focus on the people, on all the thing that matters to them, and to not try to force or to make mandatory to improve your work. Really ask the people what they want to improve, how they want to improve, and be a support to all those natural movement from the people. Everyone wants to improve their job. It's really humankind, and really something that we all want. We really want to do our best. So try to foster on that and ask the people, what do you want to improve? What matters to you in your job? And then I will help you to improve this job. As Paul Batelden says, we all have 2 jobs. The first one is the one for which we are paid to do in our organization. And the second job is really to improve this first job. So I think we really put all this and to bring back more humanity, more joy at work, quality of life at work. It's really the central point if we really want to improve the system that is for the moment really in crisis, and not a COVID-19 crisis, really a crisis in terms of burnout rates, in terms of consumption of bulk product in the system, in terms of shortage of staff. Everything is related to the quality of life at work. And so really ask the question, what matters to them, what matters to the people, what is important for them, and how we can help them to do their job as the best they can.
Mm-hmm. And about just conducting future quality improvements, I would just say, stick to methodology, just set an aim, put a plan, continuous learning, and just test and adapt so you can adopt. That can serve as a conclusion, I think. So thank you everybody for connecting in. Thank you, Quentin and Mathieu,
Thank you.
for the nice presentation. This presentation is will be put online, so you can also just send it to your colleagues if you want. So thank you everybody and have a nice afternoon. See you next time.